In 42% of U.S. counties, women's life expectancy is decreasing. Shocked? I was too. Hadn't we come a long way, baby, from the dark days when cervical cancer was the #1 cause of cancer death in women? The days when breast cancer needed more, quote, awareness? Hadn't we conquered perpetual pregnancies? Aren't we all eating more fresh vegetables? And don't women have more power now in medicine as well as in society at large? To try to explain it, one can parse the generational and international differences. We live in a more toxic environmental soup now than in our parents' and grandparents' day, and the lack of guaranteed healthcare is a unique driver in the industrialized world. Another explanation, to be blunt, is racism. Black women are more likely to die of heart disease, breast cancer, and pregnancy, and when researchers drill down to determine why, the salient factor is the stress caused by the daily wear and tear of being a woman of color in 21st century America. Health disparities hold true for men of color as well. But why is our health slipping when women in the United States visit more doctors, have more surgeries, and fill more prescriptions than men? Bias is a problem. Women having heart attacks and strokes are more likely to be misdiagnosed by ER docs and sent home. Women, concluded a 2017 article in Glamour, quote, are more likely to be misdiagnosed in pretty much any medical situation. Hormones are a problem. Not our own necessarily, but the endocrine-disrupting chemicals that have infused everything from lotion to tap water. Research funding is also a problem. For example, autoimmune disorders affect a stupefying 10 to 20% of the population, depending on how many diseases you put under the umbrella. And some 75% of sufferers are women, yet these diseases claim a fraction of investigative efforts. Another problem has emerged in recent years: too much treatment. In November 2009, the U.S. Preventive Services Task Force, USPSTF, an independent group of physicians and researchers that makes recommendations on disease screening, ignited a firestorm when it recommended that women get fewer mammograms. The announcement came in the midst of a 15-year-long breast cancer awareness campaign. Pink ribbons were everywhere, and the early detection saves lives mantra had been burned into the public consciousness. Despite this, the USPSTF announced that, based on epidemiological evidence, women would be better off if they held off screening until age 50 rather than 40, and screened every 2 years rather than annually. For many, it just didn't and still doesn't make sense. Why would it be better for women to screen later and less often? Sometimes you wind up sitting next to just the right person at lunch. I was at a health conference around the time of the USPSTF's Pink Grenade, and that person was Ned Kalange, then the task force's director. Kalange gave me the cancer screening spiel that he was frequently giving to audiences of clinicians at the time. There are 5 outcomes to a screening test, and 4 of them are not going to help you live longer or better. 1, the test could be wrong. You don't actually have cancer, but you get unnecessary biopsies, surgery, or treatment, potentially causing harm. 2, the test could be right in detecting some abnormality, but what it detects is never going to progress into invasive cancer. 3, the test could also be wrong in the false negative sense. You really do have an invasive cancer, but the test says you don't, so you ignore your symptoms. 4, if the test finds nothing, and indeed you have nothing wrong, you are no better off than when you began. Only in the case that the test finds a bad cancer before you had noticeable symptoms are you potentially gleaning a benefit. Kalange's point? Think before you test. In the case of mammograms, Kalange explained, the problem was that for every handful of lives saved, thousands of women were getting unnecessary, potentially harmful treatment. Years of annual screening, he said, had not delivered a net benefit. In the connected realms of overtesting, overdiagnosis, and overtreatment, women are more vulnerable than men. We're recommended bone density scans and then prescribed drugs to treat osteopenia, though the machines, diagnosis, and treatments were all manufactured by the pharmaceutical industry. And it turns out these drugs often lead to bone loss and fracture. Routine thyroid cancer screening came into vogue in the 2000s, though now we know that some 80% of the resulting surgeries, in women specifically, were done unnecessarily. Men and women are equally obese, yet women are more often recommended bariatric surgery.